Okay, now that we've had a general overview of the MR lexicon, this lecture is really going to focus on the role of MR in a patient who has just been diagnosed with breast cancer. As I mentioned before, now we'll go over the protocol for the 1.5. So basically a background slide. Why does MR work? Well, it does because we know that most cancers will enhance rapidly with gadolinium. And that really is for three main reasons. One is that there's neovascularity due to angiogenesis. So with these increased number of vessels, it actually turns out that these vessels also have an increase in vascular permeability, and therefore you could think of them as being leaky. In addition, there's also extensive AV shunting that occurs. So for these three pathophysiologic reasons, most cancers will end up demonstrating a rapid uptake and washout of contrast. The standard technique that you need to perform in your practice is to use a high field magnet, either a 1.5 or 3 Tesla. You also need to have a dedicated breast coil. Gadolinium must be administered. We use a standard dose of 20 milliliters given by a power injection, then followed with a saline flush. The ideal time to image the patient is in the second week of the menstrual cycle. That is defined as days 7 through 14. At this time, there is the least amount of enhancement in normal fibrocystic tissue. A couple of words about technique. Fat suppression, I think it's very important for lesion conspicuity. In fact, I think it's quite difficult to interpret the post-GAD images without fat suppression. The problem is it's very difficult to obtain homogeneous fat suppression across the breast. Therefore, some people have actually elected to skip fat suppression completely and rely solely on subtraction images. The problem there is that subtraction images can often be degraded by misregistration secondary to patient's movement, and therefore you'll get significant motion artifact. I mentioned this earlier. People ask me constantly, should you be performing a unilateral sagittal examination or a bilateral examination? Well, both really have their merits. If you're acquiring sagittally, you're going to have a higher spatial resolution as you really are focusing on one breast. The higher spatial resolution should really translate into an improved sensitivity and specificity. Again, on the higher field magnets, where that really is a selling point, the higher resolution, I think that's what you should do. However, a big benefit with the axial imaging is with the diffuse enhancement of normal fibrocystic breast tissue. It's much easier to do a side-by-side comparison of that quote-unquote normal enhancement. You have one breast compared to the other. The drawback is obvious. You're going to have a larger field of view. So this is our technique at the 1.5 Tesla. We are going to obtain the routine T1s and T2s. Like on the 3T, we're going to obtain initial pre-T1s and then 4 dynamic images through the breast. The views are just some special high-resolution slab images, just like what Dr. Rafferty was mentioning in a tomosynthesis talk. And at the end of all this, we actually will do a delayed axial T1 vibe, looking at the normal fibrocystic enhancement in both breasts. And this technique takes about maybe 22 minutes to perform. So now let's get into this topic. The current indications for MR and breast cancer, the biggest one is staging of known cancer. This is an extent of disease evaluation. You're trying to determine if there's any additional cancer in the same breast or in the contralateral breast. The next indication is in a patient where you're trying to find the primary tumor when they initially present with a metastatic axillary lymph node. Next is evaluation of a scar. Here, there's been a change in the appearance of the scar in the mammogram, and you're assessing for recurrent disease. Another area is really monitoring response to drugs. Usually this is just in the neoadjuvant chemotherapy setting, and also in surgery to detect for residual disease. So let's talk about staging of known breast cancer. You really are trying to see how much cancer is in there. So you may be seeing multifocal, which is disease defined as within one quadrant of the breast, or multicentric, which is disease in multiple quadrants of the same breast, or in contralateral disease, which is especially common in patients with invasive lobular carcinoma. So this is an example. A woman had dense breast palpable mass, which is mammographically occult. On the MR, again, everything I'm showing you is going to be post-GAD subtracted images. You can see this is an irregular homogeneous enhancing mass, which corresponded to the known cancer. However, as we continue to scan this patient, you can see more towards the center of the breast, there is this diffuse segmental clumped enhancement going towards the nipple, which is quite extensive. And in addition, in a separate quadrant, there's another smaller tumor. This is the classic spiculated rim enhancing mass. So if the surgeon were to go in there and just remove this palpable lump, he may or may not get positive or negative margins. However, despite giving radiation and chemotherapy, you can see that there is extensive disease that is left behind in the breast, and this patient really is much better served with a mastectomy. What we've known so far from the data on MR is that it's very accurate in assessing the size of primary tumor. In fact, the larger the tumor, the more accurate MR is compared with mammography, ultrasound, and clinical breast exam. Multiple reports also shows that up to 1/3 of the patients will have an additional foci of disease in the ipsilateral breast. These usually turn out to be DCIS, which is not seen mammographically. In the contralateral breast, Laura Lieberman from Memorial has published data showing that in 5% of the women, there will be a finding in the opposite breast, which warrants further evaluation. So this is an example. Patient, known cancer, irregular mass, and in this patient, another small satellite lesion that was seen. However, as these were the only 2 lesions, an attempt could be made at breast conservation. So is all this new information at the end of the day? No, the pathologists have known for many years that when they review their specimens that there is a lot more disease than what we can detect with mammography and ultrasound. In fact, Holland published a study back in 1985 looking at patients who underwent mastectomy for multifocal disease. Only 1/3 of the patient was there no additional cancer found. 20% of these patients, there was multifocal disease just within the same quadrant, and then 40% of the patients, there actually was some cancer further away. So if you actually take a minute and think about it, this actually is kind of surprising. So when a surgeon operates for a known cancer, we actually know that there is a high chance of residual disease being left behind in the breast. Therefore, what we hope is that these patients will be adequately treated with follow-up radiation and chemotherapy. And for the majority of patients, this is fine. However, in a small percent of patients, they will then end up presenting with recurrent disease. And this is the data that I was talking about earlier. Multiple studies show that in about 1/3 of the case, we're seeing multifocal or multicentric disease. The last 2 columns, I think, are more important. And about 25% of the time, there's a change in therapy. Patients end up getting chemotherapy up front instead of having surgery right away. And in about 15% of the population, they're actually converted from a lumpectomy to a mastectomy. So here's such a case. This patient presents with a known cancer, irregular homogeneous enhancing mass, which was palpable. And what else do we see? Well, there's a segmental clumped enhancement, suspicious for DCIS, but in addition, there are multiple round homogeneous enhancing mass, certainly suspicious for adjacent satellite lesions. And when you're evaluating these patients, it really is important to look at multiple planes, because here it only looks like it's only a few centimeters from the primary tumor, but on the axial images, you can see how far away it really is located. Another entity where we're tending to see a lot is something called an extensive intraductal component. This is a case where a patient presents with a solid mass, irregular on mammography. The pathology report demonstrates that more than 25% of this mass contains DCIS. In these cases, you should really recommend an MR to see if there is any other DCIS left in the breast. As you can see, this breast is pretty fatty, and I assure you that there is no calcifications. However, on the MRI, here's a known cancer, and again, you can see the extensive segmental clumped enhancement, which is not seen in a pretty fatty breast. Another area now we're talking about is multicentric disease. This is cancer, again, in multiple quadrants. Known cancer, patient has actually metastatic lymph node, and you can see this segmental clumped enhancement nicely on the sagittal, coronal, and axial view. Sometimes we'll obtain these are called MIP images. You sort of can get a feel of really how extensive the tumor is. I like this a lot for looking at the clumped enhancement pattern. But here you can see there is disease which begins at the nipple and actually extends all the way to the axilla. And as I mentioned earlier, once you see a lesion, we're going to go ahead and plot the kinetic curves. Again, sometimes I'll place the ROI in a spot where I see the most enhancement. That'll increase my chance of getting this type 3 malignant curve. Something else which we're starting to rely a little bit more on is actually using a color map. And here you can see this suspicious lesion has the same blood flow as a normal heart, and therefore you can presume it is a highly vascular lesion. So with multifocal disease, a lot of times the number one question is, can this breast be conserved? Again, primary lesion, multiple satellite lesions. In this case, an attempt can be made at breast conservation by bracketing. You're going to place a wire delineating the most anterior and posterior extent of the tumor. Where else can it be helpful? Well, in cases where actually you're really surprised that there's going to be malignant disease. This patient presents with a pretty well circumscribed mass in the breast. On a mammogram, there actually was a suggestion that perhaps it could be a hamartoma. However, when we performed a T1 without fat set, you can see that the fat in the breast is bright, but there's absolutely no fat in this lesion. This is the case I showed you earlier where there was central enhancement. This actually turned out to be a phyllodes tumor. Normally, if we get that, then the surgeon will go in there and just resect this mass. However, as we scanned further, we saw that there was significant adenopathy, and this ended up representing a malignant phyllodes. Once you know this, the patient can have a one-step procedure of a lumpectomy with an axillary node dissection. Other cases where it's important is, again, finding unsuspected disease. Another patient, known cancer, few satellite lesions, and what we see here is a little small irregular enhancing mass, which actually represents an internal mammary node. And this is important because when a patient is given radiation therapy, the port usually does not extend so far medially, and therefore this lesion would not have been treated. Another case is what I showed you earlier, the inflammatory breast carcinoma. I think MRI demonstrates it beautifully. You really get correlation with the clinical breast exam. Right away, you see this left breast is significantly larger than the right. You get to see the classic skin thickening and trabecular thickening. In addition, what you can see, actually in this case, you can identify the focal primary tumor in the breast. And I think MR is excellent for monitoring response to treatment, as this patient will also get chemotherapy up front. The other topic is invasive lobular carcinoma. This is a cancer which is really best seen in one plane. It's a very insidious spread of these single Indian file cells, and we know that in predicting not only finding the tumor and then predicting the full extent, mammography, ultrasound, and clinical breast exam together is limited at most 33% sensitivity. MR is much better at 85%, but certainly not 100. And here's a case I showed you earlier. Patient presented with a palpable mass, speculated corresponds to its irregular mass on the MRI on both sagittal and axial plane. And when you actually scan the opposite breast, here was a occult large mass which is completely unsuspected in the contralateral breast. So once you've done the extent of disease, you really need to see is anything else involved. And the two things you need to look at is the pectoralis muscle and also if there is any chest wall involvement. And if there is pectoralis muscle involvement, then the surgery is changed from a modified radical to a radical mastectomy. If there's chest wall involvement, the surgeon will not be able to get negative margins, and therefore this patient again will get chemotherapy up front. Here's an example. Patient presents with a large tumor, and you can see how easy it is to measure this mass on MR. Coronal images, you can see some central necrosis, which you can appreciate that there are some spicules extending from this mass. And back here is the area of interest. Some spicules are extending towards the pectoralis, and there is a loss of the fat plane. However, there is no enhancement of the pectoralis muscle. Therefore, you cannot call this invasion of the pectoralis muscle. That's in contradistinction to this case. This patient presented a large cancer, and again, here you can see now there's enhancement of the pectoralis muscle. Right away, you'll say, okay, then this patient needs to have a radical mastectomy. However, you look more carefully, now you can see that there's enhancement of the intercostal muscles. The surgeon, again, will not operate on this patient. And this is an important distinction because you'll think, oh, a large tumor, I'm not going to make a difference anyway. In this case, you really are. Another case, patient has a large satellite lesion. The red arrows are pointing to 2 normal ribs, and you can see there's a satellite lesion which has implanted into the chest wall. Both patients are not operative candidates. One more slide just to make the distinction very clear. If there's pectoralis muscle involvement, that's okay. But if there's chest wall involvement, and that's defined as serratus anterior and intercostal muscles or the ribs, then the patients are not an operative candidate. So let's go on to the next topic, which is identifying the unknown primary breast carcinoma. Patient presents with a palpable lump in the axilla. Biopsy is performed, which shows adenocarcinoma of unknown primary. In this case, if the mammogram is negative, the MRI is the test of choice to detect for occult disease. What have we found so far? On MR, the tumors are small, all less than 2 centimeters, which explains why it is usually occult on clinical breast exam and mammography. And the literature shows that the sensitivity of MR in this select population is very high, from 90 to 100%. Here are some examples. This patient presented with a palpable lump in the axilla, and in fact, on MR, we can see that there's actually extensive adenopathy. And when we were imaging this patient, we just saw a slight focal area, which looks a little bit more brighter than a normal breast tissue. So again, a little bit suspicious. And when we look at all 3 planes, this is a focal area of heterogeneous enhancement. In fact, this turned out to represent the patient's primary tumor. 2 other cases, you can see usually these patients have pretty dense breasts. I really can't find a tumor in either this mammogram or this mammogram. But once you find this cancer, really the patient's treatment is altered. Now they can go ahead and have a lumpectomy. Now they can really find this tumor and find out what chemo regimen the patient will best be served by. Without finding the tumor, the majority of these patients go on to a bilateral mastectomy. So now let's talk about evaluation of a scar. This is really twofold. One is the patient was just operated on, and you are looking for residual disease. The surgeon comes to you and has a path report showing positive margins. And really the ideal time to scan in this case is within 2 weeks of surgery. That's before you have extensive granulation tissue that will set in. The other times the patient already has a history of a lumpectomy, but then you're worried about a recurrence because there's a change in the appearance of the scar on a mammogram. A typical scar on MR is going to be defined as a linear band of enhancement that really is in a non-anatomic distribution. Occasionally we've performed MRs for where the pathology result is benign, but there is discordance with the radiologic studies. So let's go ahead and look at some examples. This patient was recently operated on for DCIS, positive margins. So in this case, you're really not looking for microscopic disease. You're trying to tell the surgeon if there's any big residual bulky disease left behind, because that's going to change his surgical planning. And in fact, another benefit of scanning early on is that you can see a large seroma cavity, which then sort of serves as a negative contrast, and I think it's very easy to evaluate the seroma wall. Again, this stands a little bit, but you really cannot call this suspicious for residual disease. Incidentally, in this patient, we actually saw another irregular mass, which turned out to be an unsuspected tumor in a separate quadrant of the breast. Liz Morris has published a study looking at the accuracy of MR in detecting residual disease. And in fact, MR is very accurate, up to 86%. And as you would expect, is more accurate in finding multicentric disease because really this is disease which should have been detected upfront in these high-risk women. And it's least sensitive around the biopsy site, and that makes sense because you're going to have limited sensitivity as there will be overlapping with the normal granulation tissue. So here's an example, T2 images, and now the seroma cavity is going to be bright. It's filled with water, and you can see these gentle dark septations. You would see these equally well with sonography. And in this case, you can see thin wall and large bulky tumor. So really, the bulk of this tumor was left behind in this patient. Again, important information to alert your surgeon. What we found is really in women who tend to have this residual disease, it really is in young women with very dense breasts. Again, it makes sense because that's where you're most limited by both your clinical breast exam and your mammography. So this patient has some calcifications, which really we don't see, positive margins on pathology, and in fact, you can see a little bit of residual clumped enhancement. Since this wasn't that big of an area, an attempt was made at breast conservation. And in contradistinction to the earlier data, actually MR isn't as good for detecting residual DCIS. And again, it's probably because sometimes it really is hard to appreciate that clumped pattern, but an abstract presented by Jennifer Manel, also from Memorial Sloan Kettering, just shows that MR just slightly outperformed mammography. But here's an example of one of our recent cases. A patient had a excisional biopsy for DCIS, and they said there was multiple borders had showed positive margins. On MR, you can see this is that segmental clumped enhancement, but also what you see is an irregular enhancing mass, a totally unsuspected invasive carcinoma. And further down, you can see now here's the seroma cavity. This patient was imaged a month out, and you can see how much harder it is to evaluate this seroma cavity compared to the case that I showed you. In this case, as you can see, the enhancement really extends pretty much from the anterior to posterior depths of the breast. Therefore, breast conservation is not possible, and this patient went on to a mastectomy. Now let's shift gears and talk about neoadjuvant chemotherapy. This is the new way of treating patients with locally advanced disease. In my institution, this is defined as a primary tumor that's more than 3 centimeters in size, and also a patient who at presentation already has positive axillary lymph nodes. And now again, studies have shown that MR is great in monitoring the response to chemotherapy. And in fact, the amount of residual disease that you see in MR can be used to prognosticate how the patient will respond overall. And the reason why MR is so good is because it's not limited by overlying fibrosis, which certainly limits the mammography and clinical breast exam. So here's examples. Large tumors, and after chemotherapy, only a residual amount of disease. Similar, segmental clumped enhancement after surgery, just a tiny little focus is seen. Both patients can now go on to lumpectomies, and you'll expect that they're going to have a pretty good outcome. So how much significant disease is left behind? This patient, breast was completely filled with tumor, complete dense enhancement. After neoadjuvant chemotherapy, you can see these areas enhance less, but there's still, I call it, some residual disease. Actually, at pathology, no residual disease was seen, and they thought that this enhancement was actually just due to inflammatory changes secondary to chemotherapy. This patient actually was not so lucky. Again, large speculated mass, and after chemotherapy, you can see the mass has certainly become much bigger, and in addition, there are new lesions. So now the whole idea is maybe it's worthwhile to bring the patient back for an MRI before the whole 6 cycles of chemotherapy has been completed. And if you can see this partial response or even progression of disease while on chemotherapy, then an attempt should be made to change the chemotherapy in order to try to improve this patient's morbidity and mortality. Just a couple of points about the Bio-Rad assessment. If you're already doing an extent of disease evaluation, ideally you should give a different Bio-Rad assessment for each breast. An important point I get asked a lot is you really need to biopsy whatever is the most suspicious finding. So if the patient has suspicious calcifications on a mammogram and the MRI is normal, at the end of the day, the mammogram finding is still suspicious, and therefore a stereotactic guided mammotome biopsy should still be performed. Dr. Frenda mentioned this earlier. Really, the most reliable landmark if you're going to do a targeted ultrasound is the distance from the nipple. In addition, you're also going to lower your threshold. So if you were going to dismiss a finding when you were initially there, but now because the MRI has served as a roadmap, you're going to be a little bit more suspicious. Our general rule is if the enhancing mass is greater than 5 millimeters, it really should be seen on ultrasound. And this is sort of a working algorithm. So on MR, you see an enhancing mass. If it's by RETs 2 or 3, great. You can recommend the appropriate follow-up at either 6 or 12 months. However, if you're classifying a lesion as by RETs 4 or 5, then you're going to go ahead and look at the size. If it's more than 5 millimeters, you're going to further interrogate it with sonography and ultrasound. If you see a lesion using either modality, great. Then you know how to approach this lesion. If you don't, then you really should perform an MRI-guided biopsy. The hard part again is in these little small foci. There, I think you really need to figure out your level of suspicion. And if you are suspicious, an MRI-guided biopsy should be pursued. And just to show you an example, this patient, I actually really wasn't sure. This mass looks a little bit spiculated on the axial view, but it was quite hard to see it on the sagittal view. We brought the patient back. Here's a mammogram. Very dense mass, no focal lesion. And in fact, we did the spot compression views. You can see a little bit of an irregular mass. It was occult on sonography. Therefore, in this case, stereotactic guided mammotome biopsy was performed, which ultimately revealed an invasive ductal carcinoma. So just a couple of words about MRI-guided procedures. They're hard to perform because you're relying on contrast enhancements, and there can be rapid washout. And as Dr. Frenda shows, there's no specimen radiograph. So if you get a benign pathology result and you're wondering if there is any discordance, the best thing to do is to bring the patient back for a follow-up MRI. Regardless of whether you're performing a needle localization or core biopsy, these are long procedures which will take 45 minutes even after an initial learning curve. And a general rule is you really should repeat the MRI prior to performing a procedure if the index lesion was seen on an outside MR. That way you know the lay of the land before you go in and perform a biopsy. These last few images are actually courtesy of Cirrus, which is one of the makers of a vacuum-assisted device which is MRI compatible. These are examples of biopsy coils, and this is the compression grid through which the breast is placed in. And along with the grid comes several devices. This is an obturator which would just present a signal void so you can identify the lesion. And here's a needle guide, so you can either place a tiny needle if you're performing needle localization or a larger hole if you're performing a core biopsy. In addition to that, there is a stylet and an introducer sheath. So here's the patient. She's laying down on a breast coil. Here's the patient's head, and the breast is laying in here. And what you do is you do some initial images, and once you're able to identify where the target area is, you're going to place the needle guide into the appropriate grid. So you're going to count 1, 2, 3, 4, 5 back and 1 down, and that's where you know to place the needle guide. After you place the needle guide, you're then going to go ahead and place your obturator. The obturator comes across as a black signal, and here you see the tiny enhancing mass, which was the index lesion. Once you see this, then you can go ahead and pursue the biopsy. The Cirrus device can then be automatically inserted through this needle hole. Back here, which is obscured by the hand, is actually the sample chamber. And afterwards, you perform the biopsy. You again place in the obturator at the end of the study. You'll perform some post-biopsy images to make sure that the lesion has disappeared. And here you can see, using this Cirrus device, you really get very large samples. So on this slide, I'm going to end this talk, hopefully give an overview of the ability of MRI to guide your surgeon and to provide the correct management when patients diagnosed with breast cancer. Thank you.